And the recording will start as well once we're live.
Okay, perfect.
Can you guys see the main slide now? Is that?
Yeah.
Yeah.
I don't know where the logo's gone.
Hi guys, this is session 2 for rheumatology. We're just going to give it a couple of minutes to see if anyone else joins and then we'll start.
Should we say we'll start at 5 past for everyone just filtering
Yeah,
in
that
now?
sounds good.
Don't worry guys, we'll keep it nice and concise this evening. We won't keep you past 8.
Yeah, and if you want to put anything in the chat, I'll monitor it for you guys.
Are we recording, Lucy? Or we haven't started
Yeah,
yet?
I'll be recording from now.
From now, okay. Right guys, we'll start in a minute or so. Doesn't look like anyone else is joining. Let me just get everything up. And we'll give it 30 more seconds, I think. Right, guys, I think we'll get started then. So thank you everyone for coming. This is teaching session 4. We'll get into what we're going to talk about in just a minute, but a quick disclaimer before we start. So I'm Joe. Nice to meet you all. I'm a current F1 working in rheumatology. Obviously, everything in this teaching session is geared towards your learning and exams. It's not necessarily to be directly used in place of guidelines or clinical knowledge in practice. Please, guys, feel free to reach out with any questions throughout. Just send messages in the chat. And Lucy, who's helping out and has kindly arranged all of these teaching sessions and delivered the first session, I believe, will help me out and read them out and help answer them. So all X-rays and clinical photographs have been taken from open source websites and Radiopedia, the like. So they've all got patient consent. None of them are from my own clinical practice and the like. But please, guys, want to make it as interactive as possible. So please just send anything in the chat if you want to ask at any point. So starting with the structure of today, we're going to break it down into 2 core components of rheumatology that are pretty different. So we'll start with gout and the broader spectrum of disease referred to as crystal arthropathies. So that includes pseudo gout, which are common topics for exam questions and could crop up in your OSCEs as well as multiple choice. And then we'll move on to a much more complex and more interesting, possibly, topic in vasculitis, but we'll just cover it in a brief introduction to vasculitis, and then we'll go over the classical conditions that you see in exams and which associations to look out for in those single best answer questions. So hopefully we'll have you guys prepared if any of this crops up in your upcoming finals or wherever you are in medical school. So we'll just start with a bit of recap. So how to assess a red or swollen joint. So back to our principles of any MSK or joint exam. So does anyone want to shout out a few questions you might ask if you were asked to come and examine someone? How would you start? Does anyone have any particular any points in the chat? Not that I can see right now. But yeah, so on the slides, as I've got there, we start all histories with Socrates, don't we? We want to know which joints are affected, and we want to know when that came on. Was it a gradual onset? Was it a rapid onset? We want to know the character of the pain, and we want to know where it localizes to or where it radiates to. So often that can give us a really good clue. We know that pain radiation can tell us a lot in terms of, for example, shoulder tip pain or pain in the ACJ joint, the acromioclavicular joint, can radiate to the neck. We want to know any associated symptoms. So does a person have any fevers? Do they have any other constitutional symptoms? And we want to know about which joints are affected. So does anyone know how we classify different types of arthritis in terms of if 3 joints are affected, what would we call that? I don't know if anyone in the chat can send the definition. So if we call an arthritis affecting one single joint a monoarthritis, what would we call an arthritis affecting 3 joints? I don't know if anyone's there in the chat.
Nothing in the chat. Is it
Nothing so far.
polyarthritis or polyarthropathy?
So yeah, exactly. We've got polyarthropathy and we've got an oligoarthropathy in between a monoarthropathy and a polyarthropathy, usually in which 2 to 3 joints are affected. So our basic principles of any joint examination, and then more seen in your orthopedic assessments, are look, feel, move, and function. So we're going to observe a joint. We're going to see, are there any skin changes overlying it? Is there any clear swelling of the joint and the like? And then we're going to palpate the joint. So we're going to start with the joint itself and any surrounding soft tissue structures, tendons, the related muscles to the joint, and so forth. And then, of course, we're going to think about, in any OSCE or any clinical examination, what are our must not miss diagnoses relating to that joint. And there's some particularly important ones in regard to gout, which we'll get onto in a minute. So moving on, when we think about gout, it's caused by chronically elevated blood uric acid levels, sorry, not urea. So hyperuricemia. And what occurs in the disease process of gout is you get uric crystals depositing within the joint. Now, it's more common in men. It actually accounts for around 250,000 GP consultations each year. And we know it's more common with increasing age. So you can see there, it's most common in the middle-aged and elderly. With gout, there's some specific clinical features we think of, and that's acute onset of severe joint pain, and it typically affects certain joints. So I don't know if anyone knows which joints are affected most commonly in gout. If anyone can send in the chat, if anyone's available, just send into the chat, guys, if you know which joint is most commonly affected in gout. Or if not, we know it's actually the first metatarsophalangeal joint, so the first big toe, that metatarsophalangeal joint, and that's sometimes called the podagra. The initial attack of gout, so the first, we usually refer to gout as an attack. So an episode of gout, you'll often hear to referred as an attack, and that tends to occur in the 4th to 6th decade of life, so in your 40s, 50s, 60s, and then that's particularly in men, and in women this coincides with the postmenopausal period, and it usually affects just a single joint. Now we know it's most common in that first MTP, but it can also affect your wrist, elbow, ankle, or knee, but it tends to be that first MTP classically in an exam. Now, when an attack comes on, it usually reaches peak intensity within 4, 5, 6 hours, and patients will describe they're completely unable to put any weight on that joint or use that joint, and often we see this classical history of a hot, excruciatingly painful joint. So other clinical features of gout, we see skin changes, so gouty tophi, they're yellow vesicles, depositions of these uric acid crystals within the skin. And then we know we've got some risk factors for gout. So as we already mentioned, it's more common in men and in people of increasing age. Obesity is a further risk factor. There's a lot of lifestyle factors, which we'll get on to in a minute, which there's a limited evidence base for how much it actually contributes to gout. But people say a purine-rich diet, that means a diet rich in oily meats and the like. And of course, alcohol, most classically beer, can cause gout attacks. So there's some particular medications we look out for in gout, and they're diuretics, and also cytotoxic drugs. So if we think logically, it's things that either decrease the excretion of uric acid or increase the production. So cytotoxic drugs are causing lots of cell breakdown, apoptosis, and increase the amount of uric acid circulating in our blood, elevate that uric acid level. Diuretics are increasing excretion of certain products, but uric acid, some diuretics can increase the level of uric acid. And finally, renal failure, so we're unable to secrete uric acid in the urine. So cell lysis, as I said, renal failure. Specific drugs to look out for on top of that are like cyclosporin and some of the TB related medications such as ethambutol. So moving on, we've got investigations for gout. So classically we do 3 things, and that's number 1, we aspirate the joint using aseptic technique, and we'll get on to that in a minute, but we can see here the classical finding on joint aspiration when we look under a microscope. So I don't know if anyone knows what we call these particular crystals or what their specific term is for that. And then here we have a classical gout X-ray in which you can see that first MTP. There's some erosive change around the joint, and there's some additional deposition. You can see some thinning here of the bone. So we do 3 things. We take a blood test for serum uric acid level. Now that can actually be normal in an acute attack of gout. If you think all of the uric acid is being deposited within the joint, we aspirate the joint and we look at it under a microscope, and what we see negatively birefringent crystals, and they're needle shaped, as you can see in this microscopy image. And then we have some classical findings of gout. So we lose the joint space a bit like in osteoarthritis. We get these slightly lytic lesions in the bone, and we can get these erosions. And sometimes you can call them punched out. Now that's the investigations in gout, and on to the acute management. So importantly, we need to start something in that acute episode to help people. They're in significant pain, often it's quite debilitating. So what we usually start is either a non-steroidal anti-inflammatory or colchicine. Now we would continue these until after the attack of gout's finished, until probably 24 to 40 hours after the attack's finished. And remember, whenever prescribing non-steroidal anti-inflammatories. You need to prescribe some gastroprotection, so a PPI, omeprazole, or lansoprazole. Now, with colchicine, it has some very specific side effects that you classically see in exams. So I don't know if anyone knows what those are, but we often hear of patients having GI upset and diarrhea with colchicine. So sometimes it can be very poorly tolerated, in which case we have to look at other alternatives. Now, we know a lot of patients who have gout. We just heard that renal failure is a risk factor. They might not be able to take either colchicine or NSAIDs because they're contraindicated in significant renal impairment. So what can happen is patients need a short course of steroids, which is actually off-label, but it is recommended by NICE. And then even in some cases, rheumatology departments may treat patients with more specialist sort of DMARD medications, DMARD meaning disease-modifying anti-rheumatic drug. And one of these is an IL-1 inhibitor called anakinra. So if all other treatments are contraindicated, sometimes that can be used. So yeah, and then a final consideration is sometimes they'll do intra-articular steroid injections for gout if all else fails. So moving on to prevention of gout. So the principle is basically to lower the serum urate level so that we reduce the risk of further episodes of gout flares or attacks. So we do that with two things, and the first line medication is allopurinol. Now, previously there's been some schools of thought about needing to wait for a second or a third attack of gout, but the current guidelines from NICE say you can treat with urate lowering agents, allopurinol, after the first attack. So allopurinol is first line and febuxostat is second line, and they're both working the same way. They're both xanthine oxidase inhibitors. Now, allopurinol's more popular, and possibly because it's got some more evidence in terms of its risk or risk of lowering cardiovascular disease. So that's where we stand with prevention of gout. So remember, classically we start allopurinol or febuxostat, and usually that will be done after the acute episode. So you wouldn't start both colchicine and allopurinol at the same time. You'd wait until 2 weeks after the initial attack of gout had subsided and then start allopurinol. Now, in GPs for GPs there is some guideline about testing uric acid levels after starting allopurinol for febuxostat, and to ensure that you get sufficient response to the medication, in which case then you can increase the dose or switch to the other one. Importantly, with allopurinol and rheumatology, you need to remember there's a very significant interaction between allopurinol and another very commonly used medication in rheumatology, and that's azathioprine. So both can interfere and interact to cause bone marrow suppression and reduced blood cell counts, so pancytopenia, if co-prescribed. So that's a common interaction that can come up in exams, and that's all because basically allopurinol interferes with the metabolism of azathioprine and can cause accumulation of some of the toxic metabolic products. So moving on to lifestyle counselling, which could come up as an OSCE station in relation to gout. So we would advise all patients. These are the basic points I'd recommend you stick to. We'd advise all patients would stick to a healthy, balanced diet. NICE say there's actually limited evidence to show that decreasing your foods rich in purines can actually help decrease the risk of flares. There's not enough strong, randomized controlled trials to back that as a clinical practice. But we would also advise that patients avoid obesity and excessive alcohol consumption. Obviously, we'd advise this to anyone with regards to the health. And you can signpost patients to Versus Arthritis, which is a national organisation with basically the gold standard for leaflets and the like for any sort of rheumatological condition for patients. So it can be really helpful actually if you look at Versus Arthritis before any OSCEs, and you can go over some of the common conditions, and it just begins to jog your memory in terms of how you might explain conditions in lay terms and describe the medications used. Now we'll move on to pseudo gout. So often, if gout comes up in a multiple choice exam, pseudo gout will be one of the other differentials or one of the other options. So pseudo gout, we'll just demystify some of the terminology. It's actually the acute presentation of the underlying disease, which is CPPD. CPPD is calcium pyrophosphate deposition disease. And that's the broader term for the disease process in which calcium pyrophosphate crystals are deposited within the joints. It can present acutely, in which case it's called pseudo gout because it mimics gout, or it can be chronic. And there's different types of chronic CPPD. And now often you'll hear people conflate pseudo gout or CPPD with chondrocalcinosis, which is actually an X-ray finding of calcium pyrophosphate deposition in the soft tissues around the joint. So we'll talk about that in a minute when we look at an X-ray. But with pseudo gout, as I said, you get these crystals collecting in the joints, and the risk factors, similarly to gout, are increasing age, but it's more associated with certain electrolyte disturbances, so low magnesium or phosphate. And actually, a classic multi-choice association is hemochromatosis. So patients with hemochromatosis are at higher risk of pseudo gout. So if you see that they've got a pathological history of hemochromatosis and they present with a similarly sounding history to gout, for example, a knee that's acutely painful, that should be ringing alarm bells of pseudo gout. And it can be triggered by acute illness, trauma, surgery, and any kind of physiological insult. So moving on, the clinical features, as I said, is variable presentation, maybe asymptomatic, and that's regard to CPPD, not pseudo gout, is the symptomatic, acutely symptomatic version. It can affect multiple joints and cause chronic pain and stiffness. And on investigation, you see specifically rhomboid-shaped positively birefringent crystals. So that's different to the negatively needle-shaped birefringent crystals you see in gout. And then on an X-ray, you see this chondrocalcinosis. So we see here, we've got this presence of calcium deposition in this sort of articular cartilage around the joints, the hyaline and fibrocartilage. So often you'll see chondrocalcinosis is used as a pseudonym for gout itself, when it's pseudo gout, when it's actually not. It's more the X-ray finding you see in pseudo gout. But you'll see this in many people, especially as they're advancing in age. So it can be completely asymptomatic. But if you do see it, it's good to pick up an X-ray and narrate that you've spotted that. So the management of pseudo gout, first of all, supportive, so rest, ice, splinting. Now we do say, similarly to gout, you'd use non-steroidal anti-inflammatories, and if needed, you can use those intra-joint steroid injections. Occasionally, oral steroids and colchicine may have a role, as I've written there, but tends to be more supportive and symptomatic treatment than with gout, and we're not going after the same kind of preventative treatment as we do in gout. So guys, what's the must, back to this, what's the must not miss diagnosis in the context of a patient presenting with a red, hot, tender, swollen joint? In this case, I've said left knee, but what must we not miss? We've talked about gout and pseudo gout. Is there anything in particular that you want to flag? Anyone know? Just chuck it in the chat. Anything at all?
Septic arthritis.
Exactly. Thank you, Janet. Exactly right. So septic arthritis is in the back of your head whenever you're seeing a patient with this presentation. You need to be thinking, could it be septic arthritis? So the red flags, according to NICE, for septic arthritis are that rapid onset, severely restricted range of movement, difficulty weight bearing, particularly in children, fever, although fever could be absent, and just because they haven't got a fever, if they've got a number of these other red flags, you'd still be very concerned. Recent joint surgery, particularly prosthesis, so if they've got hip replacement, knee replacement, that's ringing alarm bells. A history of trauma, especially if they've had an open fracture. IV drug use, and of course an open fracture is a risk factor for osteomyelitis as well as septic arthritis. So IV drug use, and part of that is because patients with IV drug use who may have engaged in IV drug use are at higher risk of what we call a bacteremia. So they might have bacteria seeding in different parts of the body and causing infection locally there, and immunosuppression. So if someone's diabetic, or if they're on long-term steroids, or if they're on any of these, weird and wonderful DMARD medications. So how do we manage this medical emergency? So thinking in OSCE terms, always think about what context you're in. Are you in a GP practice? If you're in a GP practice, obviously you're not going to be putting a needle in someone's knee and prescribing IV antibiotics. You're going to be referring straight to the emergency department for assessment there. But if you're in a hospital, if you're in A&E, you're going to be speaking to whoever, depending on your local policy, investigates and treats septic arthritis. That might be usually orthopedics, but could also be rheumatology or infectious disease. So remember, we always want to try and get some joint aspirate before starting IV antibiotics, but if it's going to delay antibiotics, we'd go ahead and do that. And we send that for a gram stain, microscopy, cultures, and sensitivity. So we want to look at, the gram stain is the first thing you get back. That's just someone staining the joint fluid and saying, yes, there is a presence of bacteria which take up the gram stain in their cell wall, or no, there isn't. And then, of course, we want cultures and sensitivities to identify what's there and if it's amenable to whatever antibiotics we're giving them. And then we start IV antibiotics. So flucloxacillin will be first line generally in septic arthritis, although clindamycin if they're allergic to penicillin. And if MRSA is suspected, for example, they've got previous infection with MRSA, or if they're known, if they've post-surgery and they're known to have a positive MRSA swab, then you'd probably start vancomycin. But obviously that would be guided by your local antibiotic guidelines. So we'll move on to vasculitis. That essentially covers those three conditions. So gout, pseudo-gout, and septic arthritis. Does anyone have any other questions they wanted to ask before we get stuck into vasculitis? Anybody? And thank you, Olga and Lauren, for answering. So I didn't see you'd also said septic arthritis. Exactly. Any questions from anyone at all? No? Anything at all? Anything that you want to know or are unsure about or want clarification over? Be happy to go back to it. But if there's nothing, we'll move on to vasculitis and crack on with that. So vasculitis is a large topic, and it can really cover. It can be very limited in terms of its presentation to just one organ, such as the skin or the kidneys, or it can be multi-system and mimic lots of other conditions. So we really classify it by its involvement, and that means, broadly speaking, it causes inflammation of the blood vessels, but it means by which blood vessels is it causing inflammation within. So is it the small capillaries, which we would call, which we tend to expect to affect someone's kidneys and the glomerulus, or is it the medium vessels which supply the smaller vessels, or is it the larger vessels such as the aorta and the branches of the aorta, which we see in some of those conditions there, GCA, giant cell arteritis, and Takayasu's arteritis. So we'll go through each of these different conditions, and I'll discuss some of the salient points which you should be looking out for. This will focus more on the clinical presentation and the symptoms and investigations, or initial investigations, less so the management. I mean, the management tends to be fairly unanimous with regards to most of these, in the sense that they usually involve some kind of immunosuppression with steroids, followed by stronger immunosuppressants such as cyclophosphamide. But we'll get onto that in a bit, and we'll mainly focus on the symptoms to look out for, because that's when you classically, I think, vasculitis will come up in regard to your multi-choice exams, your UKMLA. Now, it's not mentioned in the curriculum, but it does crop up quite a bit, and a lot of these conditions have a lot of overlap with other topics, not just rheumatology. So giant cell arteritis comes up as a differential of a headache. particularly unilateral headache, and it's very important in any sort of headache-related questions. Kawasaki disease, we know, comes up in regards to pediatrics, so there's Henoch Schonlein purpura, and then a few of these can be classic questions in renal, renal related presentations. So clinical features of vasculitis. So we see this term vasculitic rash, and that can mean quite a lot. A rash in vasculitis can present in a myriad of ways. You can see purpura and petechiae. So this is quite an important differentiation. So we often hear someone's got a purpuric rash, and that's obviously classically associated with meningococcal septicemia, and we're very worried, and that's a red flag, isn't it, for referral to A&E, or if you're in GP, or if you're in A&E, to start IV antibiotics and the sepsis protocol. But what does it really mean? Does anyone know the difference between purpura and petechiae? Anyone in the chat at all know the difference between purpura versus petechiae? So the difference is actually it's purely based on size. So if anyone's done their dermatology placement and they know the difference between, for example, a macule and a patch, a purpura tends to just be a much larger, or a larger area of sort of blood-coloured discoloration caused by vessel damage and inflammation, whereas petechiae is smaller. So petechiae are tiny dots, usually smaller than 2 millimeters, whereas purpura are larger, and even larger than that is bruising or ecchymosis. So it's quite an important distinction that often gets passed over. And then we see this term paniculitis, which is a classical description of a vasculitic rash. So I'd encourage you to all look those up in your own time on Google, or various other websites such as DermNet. Now we get joint and muscle pain in vasculitis. We can also get neurological involvement, so you can have both central nervous system involvement and peripheral nervous system involvement. And we often get renal involvement. We can see GI symptoms. So if you think about your mesenteric vasculature, so the blood vessels that supply your gut, can be involved. And we classically always see systemic symptoms, so fevers, weight loss, night sweats, and fatigue. So vasculitis can really mimic any of these various bodily systems and the conditions that can affect them. And I think if you look at those systemic symptoms of fevers, weight loss, night sweats, and fatigue, what else could be a differential? Obviously, malignancy or lymphoma, or specific types of malignancy would be a differential with all of those. So vasculitis can similarly mimic presentations of certain malignancies, and it could be a good option to say if you were asked to suggest differentials. So first we'll start with small vessel vasculitis. So starting with granulomatosis with polyangiitis. Now this is often simplified to just GPA. So granulomatosis with polyangiitis, previously known by a different name, used to have it was named after someone else, for which it's called Wegener's, but no longer because of that person's associations. And it classically presents with a triad of ENT symptoms, respiratory symptoms, and renal symptoms. So we see histories of sinusitis, nasal crusting, recurrent nosebleeds, and classically this nasal bridge collapse. So here's a photo from Google. Does anyone else know what else could cause nasal bridge collapse? So what else can cause this kind of, if anyone knows other causes, just put them in the chat, of nasal bridge collapse. Any other ideas, guys? What could cause deformity in your nasal cartilage and septum like that? Don't know if anyone
Substance
knows.
misuse?
So exactly, yes. So Lucy's entirely correct. So cocaine use can be associated with that. There's an obvious one, that's trauma. So if someone plays contact sports and they've been received repeated trauma in that area, it can cause that. There's a few others. So people can be born with it can be congenital. So that's an important question to ask. When does your nose look like this from? Do you use any recreational drugs? Next, there's another rheumatological condition called relapsing polychondritis, which can affect the cartilage of the body, so the ear, the pinna, and the nasal cartilage, and can cause similar picture. So it's just it's quite a specific sign that you often don't see, in many conditions, and often possibly not in exams, but the easiest thing to do when trying to diagnose a condition is think about the rarest way it's manifested in. And if a patient presents with nasal bridge collapse, there's only a handful of causes of that. So we often see these patients can present with cough, wheeze, and hemoptysis, so coughing up blood. Now, the renal involvement is difficult to clarify in a history, but often you'll see like someone's urine dipstick in the single best answer question, and it will have, if they've got rapidly progressive glomerular nephritis, it will have protein and blood on it. And classically, of course, we need to know the antibodies that are associated with this condition. So small vessel vasculitis tends to be what we call ANCA positive. So ANCA is one of the antibodies which are often sent as part of a rheumatology panel, and it's particularly the C ANCA or PR3 ANCA that we associate with GPA or granulomatosis polyangiitis. Now, it's not to say that all patients, to complicate that, will have this antibody. About 80 to 85% tend to have this antibody, but in exams, all patients will have this antibody. So that's what you need to remember. So C ANCA or PR3 ANCA. Now, these patients can also have neurological signs and symptoms. They can have peripheral neuropathy, such as mononeuritis multiplex, or they can also have central nervous system involvement, which complicates things a bit, and they can have various other things. But classically, we'd see raised inflammatory markers and those sort of things in these patients. So, given this, I think chest involvement, respiratory, cough, wheeze, hemoptysis, investigations such as a chest X-ray or a high-resolution CT of the chest would probably be a good starting point to suggest if you're asked an OSCE. Now, the condition which often comes up in exams as an alternative to GPA is eosinophilic granulomatosis with polyangiitis. In many ways, can present slightly similarly with kidney involvement and respiratory symptoms, but in this case, we tend to see an atopic or allergic element, and that's where we get new asthma. So often the typical question will be, oh, it's a 40-year-old woman who comes along and never had asthma in her childhood or young adulthood, suddenly presents with severe new asthma. She's got renal impairment, blood and protein in her urine, and she's got a raised eosinophil count on her bloods. So what could this be? And if you hear any hint of asthma alongside these renal respiratory symptoms, new asthma, that should be making you think, oh, this could be eGPA instead of GPA, and in which case they tend to be more associated with p-ANCA, which is MPO. So that refers to the immunofluorescence, the pattern of ANCA antibodies, MPO or PR3. To simplify it, it's a little bit more complex, and there is some overlaps. Some patients can have GPA and be MPO positive, but it tends to be usually. P anchor is eGPA, C anchor is GPA. So really, what we know is these patients will have a raised eosinophil count, and they can have involvement of many other bodily systems, such as cardiac involvement. You might get a peri or a myocarditis, and they can have varying rashes, as we described earlier. So now let's talk about MPA, which is the final term. So you will often see this shortened to just MPA. And the core aspect of this is basically glomerulonephritis, and you can also get what's called alveolar hemorrhage, and this is part of an umbrella term of conditions called pulmonary renal syndrome. Pulmonary renal syndrome includes things like anti-glomerular basement membrane disease, so good pastures. And it basically means you're going to have hemorrhage from both the kidneys and lungs. Now, a quick way to remember all three of these is they've all got polyangiitis in their name. So the three major small vessel vasculitides that you need to remember all have polyangiitis in their name. So that can help. So now we'll move on to some medium vessel vasculitis. I'm aware it's getting on a bit. So one of the ones you need to remember is polyarteritis nodosa, so PAN. Now this presents, here's a classic picture. This is a renal angiogram where they've put a catheter into the main renal artery and injected dye so it lights them up, and taken an X-ray. So what we can see here is that we've got some little aneurysms within the renal vasculature, and stenosis of the vessels. So where the vessel walls have inflamed and squeezed in and caused stenosis. So this can present with renal symptoms, so infarct, hypertension, so high blood pressure because your renal arteries are stenosed, and it activates the renal angiotensin-aldosterone system. You can get neurological symptoms, that classically is a peripheral nervous system involvement, so mononeuritis multiplex, so basically the blood vessels that supply the nerves are inflamed. And you can get skin involvement, so purpura, livido reticularis. If people are happy with that, I would Google it if it's not something you've seen before. Spider's web, mottling of the skin. And you can get ulcers as well, so atypical ulcers which don't look like your usual arterial or venous ulcers, might make you think of something like vasculitis. Now, in exams, this can be given association with Hep B. So if you see a patient with Hep B suddenly got this strange constellation of symptoms, you might be thinking, oh, that's polyarteritis nodosa. So just remember that for your exams. Next, it's worth mentioning Kawasaki disease. It's not really, probably would fall under pediatrics if it's in medical school exams or in your OSCEs, that sort of thing. Usually in children less than 5 years. What should be making you think, could this be Kawasaki disease? If you see a child and they've had fevers for more than 5 days above, good going fevers above 39 degrees, that's what's ringing alarm bells for, is this Kawasaki disease? This is no longer your usual presentation of a viral illness. It's going on quite a bit. And then they've got these rashes. So they've got a widespread erythematous maculopapular rash plus desquamation of the fingers, so peeling of the skin on the fingers and the soles. You also hear strawberry tongue. That means a big red swollen tongue with the taste buds, the papillae, giving that strawberry skin appearance. Cracking of the lips, cervical lymphadenopathy, and conjunctivitis in both eyes, so bilaterally but without any sort of pus exudate. Now, I think it's important with this one to talk about the management. So does anyone know what the management is for Kawasaki disease? Has anyone revised their pediatrics yet? Does anyone know the management for Kawasaki disease? Just pop in the chat if you've got any ideas or suggestions. I don't know if we've got anything in the chat, but anyway, the management tends to be aspirin, and it's one of the few indications for aspirin in children. So aspirin is given for Kawasaki disease, and that's because aspirin is generally completely contraindicated in pediatrics because of the risk of something called Ray's syndrome. So a very rare but very sort of severe in prognosis syndrome where you get hepatic failure and encephalopathy. So that's interesting to know. So we treat with aspirin, but in almost nothing else within pediatrics would you treat with aspirin. So moving on to large vessel vasculitis, just to finish off. So large vessel vasculitis, we're thinking inflammation of the large vessels, so aorta and various other large vessels. And one of those large vessels is the carotid arteries and the vessels that come off, which include the temporal artery. And now this can involve some of the retinal artery, and we can get something called anterior optic ischemic neuropathy, and that's what we get in giant cell arteritis with visual involvement. So this is a really important one to go over for your exams. Often can come up as a headache differential, and now we think of these symptoms which we associate with the headache. So we get a temporal headache. So patients might say, "Oh, I've got a headache on one side or on both sides, but it's right here over my temples." They might have scalp tenderness, so it might be quite sensitive to touch. And the important thing you must ask is, have they got any change in their vision? Has their vision worsened? And it can also get jaw claudication. So when eating, they can get this pain that comes into the jaw. On investigations, we see raised inflammatory markers, ESR and CRP. And there's some particular investigations we need to think about. And in exams, it will usually refer to temporal artery biopsy. Now, in practice, this might not always be what happens locally where you work or where you get a placement, but that would often be what you see cropping up in exams. They can also do Dopplers to look for any thickening. And on this image here on the right, you can see all these inflammatory cells that have lined the inner vessel and caused stenosis and they thicken the vessel wall and cause an almost completely clogged up temporal artery. So I just thought that was interesting to include. And we can see the photo of the retina. So that's your classic optic disc edema cupping, and you can see some flame-shaped hemorrhages coming off this superior arcade up here. Now, management of GCA is always steroids. Essentially, if you suspect it, you start steroids empirically before you get the investigations back, and that would be oral prednisolone, or if there's any visual disturbance, it's an indication for IV steroids, so IV methylprednisolone. Now, it's important to also know the biopsy can be negative because you can get skip lesions, so only parts of the temporal artery can be inflamed, and so sometimes your biopsy can be negative. So what it really does is it rules in giant cell arteritis, but a negative biopsy doesn't really rule it out if you still have quite high clinical suspicion, or if if you've got raised inflammatory markers and the symptoms all fit, and if they respond very well to steroids. So the usual pattern is this unilateral headache, scalp tenderness, and it responds very quickly to steroids. And it's strongly associated with polymyalgia rheumatica. So we won't touch on PMR, polymyalgia rheumatica, in this session, but remember it's very strongly associated with that. So moving on, finally, we'll just talk about one of the more niche large vessel vasculitides in Takayasu arteritis. So the epidemiology is it's more common in Japan, Southeast Asia, and India, and tends to affect this demographic of younger women. So women in young adulthood, 20s, 30s, 40s, usually comes on as a pattern of an initial phase of fevers, fatigue, and weight loss, and later progresses to this really severe large vessel inflammation. You can get subclavian steal syndrome, stenosis of the renal arteries, so again, you get high blood pressure and aortitis, where the aorta becomes very inflamed. And the giveaway in exams will be on examination, a patient won't have any peripheral pulses. So in these patients, you might hear, on palpating the radial pulse, they've got a very weak or faint radial pulse. Tend to be younger women, and they'll have this association with constitutional symptoms, so fevers, fatigue, and weight loss. And here's a angiogram of a patient's aorta, and you can see the branches coming off there, and the beading effect almost there, and the stenosis from the inflammation of the vessel wall. So that's another. That's finally just to finish off another classic exam question, but one that's very unlikely to, I think, come up in your OSCEs. So that finishes today, guys. That was just a very quick overview of vasculitis, some classic exam associations, hopefully to give you something to think about. And then at the start, we talked about gout, pseudo gout, and septic arthritis. So I don't know if anyone has any questions just to finish off at all. Thank you, guys. I've just seen that people said aspirin to my question about Kawasaki disease. So does anyone have any questions at all that you want to ask, or are people happy?
I've just a little reminder, put the feedback form in the messages if people would be happy to do that for us.
Yeah, that'd be great, guys. If anyone could fill out the feedback, it would be much appreciated. Any questions, or no worries if not.